All right. Hello, everybody, and welcome to the Arizona State Office of Rural Health, also known as SOAR, webinar series. My name is Bridget Murphy, and I'm associated with the Arizona Center for Rural Health, as well as the Comprehensive Pain and Addiction Center. My pronouns are she, her, and Aya, and I'm pleased to fill in for Jennifer Peters, who's unable to join us today in providing some background about the SOAR webinar series. But I also have the privilege of co-presenting with Dr. Nuño later on in this webinar. But I want to let you know that the SOAR provides technical assistance to rural stakeholders to disseminate research findings, policy updates, best practices, and other rural health issues to statewide rural partners and stakeholders. The Arizona State Office of Rural Health is located in the Center for Rural Health at the University of Arizona and the Malin Enid Zuckerman College of Public Health. And this webinar is made possible through our partners at the Arizona Telemedicine Program, as well as the Southwest Telehealth Resource Center. Most of us are probably quite familiar with using technology these days in a COVID-19 world, but here's some tips for you to keep in mind is that all audience participants are on mute. We're fortunate to have Rebecca Reese with us today, who will be monitoring our chat box, and we do encourage you to enter any questions or comments or thoughts that you might have into the chat box, and at the end of the webinar, Rebecca will be reading those out, and Valia and I will be able to respond to those. The webinar is being recorded and it will be available super quick. It'll be up on the website at the end of the day, and it'll be posted on the Arizona Center for Rural Health's website, as well as the Southwest Technology Resource Center's website. Both those links are in front of you, and you can always Google AZCRH or SWTRC and find those websites. I also want to take a moment to acknowledge that the University of Arizona sits on the original homelands of the indigenous peoples who have stewarded this land since time immemorial. The University of Arizona resides on the ancestral lands of the Tohono O'odham and the Pasquayaqui nations, where many today continuously reside on their ancestral lands. It's important that at the University of Arizona that we're proactive in broadening awareness throughout campus, as well as our communities that we work and interact with, so that people feel represented through and valued. And so we do always want to make time to acknowledge where the university's homeland, where the University of Arizona sits. Also want to let you know some disclaimers. This webinar is made possible through the funding of a Health Resources and Services Administration grant, Office for the Advancement of Telehealth, and the Arizona State Office of Rural Health is funded by grants through the U.S. Department of Health and Human Services. Also want to let you know that the content and conclusions are those of the authors and not to be construed of the official positions or policies or endorsements by HRSA, DHHS, or the U.S. government. And Valia and I have no disclosures to report. So the webinar that you signed up for today is called the Evaluation of the Nurtured Heart Approach to Parenting to Improve Attention and Hyperactivity, Impulsivity in Children. I am honored to introduce Dr. Nuño. Dr. Nuño is trained as an epidemiologist and social worker. She has more than 20 years experience in project design, implementation, and evaluation in school and community settings. She teaches personal health and wellness, maternal and child health, and adolescent health at the University of Arizona, and is the director of the Bachelor of Arts in Wellness and Health Promotion Practice. An important focus of Dr. Nuño's community service, teaching, and research is engaging populations typically underserved. And probably most importantly, she is kind and bases her decisions on what's best for the communities and the people that she works with, as well as the latest and most rigorous science. I'm going to postpone introducing myself because I'm going to share a little bit more personal information in just a moment. So here we are. I'm changing hats and moving into the formal presentation. And let's go ahead and get that started. Our plan for our webinar is we're going to start with a story, and that story is mine. And it's going to show how some of the things that you're going to see and hear in the evaluation are paralleled to real life experiences, which many of you, I'm sure, are familiar with as well. We're going to provide some background on and the relevance of attention deficit hyperactivity disorder, also referred to as ADHD, and parenting interventions to address ADHD in children's ages 6 to 8. We're going to discuss recommendations for treatment. We're going to review the Nurtured Heart approach, which we'll refer to as NHA, study methods, results, limitations, and conclusions. And we're going to articulate the possibilities for incorporating NHA within scalable healthcare models. Our learning objectives throughout the presentation at the title, on each title of each slide, you'll see an LO, and that refers to which learning objective we're addressing for that particular slide. So the first learning objective is to identify the core methodology parenting approach designed to reduce ADHD behaviors in children, compare the changes in children's attention, hyperactivity, impulsivity among parents that participated in the intervention to the delayed intervention control group, and to discuss the importance of interventions that are scalable as they relate to access to care. So I want to start with a little bit of a story just to provide some context, as well as for two other reasons. One is studies show that in order to help reduce stigma associated with substance use disorders or mental health concerns, is being in contact or working with or partnering with people who have the condition really helps to reduce stigma. The second is to provide hope that people can and do change, and that over our lifetime, things can be in very, very good and maybe not so good, but throughout our lifetime, we'll also have incredible strengths and resiliency factors and other supports to keep us grounded. So I just want to start a little bit with a little bit about me. When I saw the announcement for the Nurtured Heart approach study for the program coordinator position, I was thrilled for two reasons. One, I got to potentially reconnect with Valia, who we had worked with previously, numerous years before we reconnected. And two, it was about a topic familiar to me, even though ADHD was not diagnosed when I was a young person. It certainly, I probably certainly met the criteria for ADHD. And second, it was about intervention research, which I had spent most of my career working on, looking at interventions in various community contexts to address mental health and substance use concerns. So it was kind of the best of all worlds. I got to connect with somebody that I enjoyed working with. It was personally fulfilling, as well as it met my professional experience and skills. I grew up in a small rural Midwestern town. I think our population was definitely under 10,000 when I was growing up in this Midwestern town. It was a town that was tight-knit. It was also in the 70s, in which there were very different social norms about alcohol use and tobacco use. And there was also different social norms about differences in races and ethnicities and people that you interacted with and who you didn't interact with. And it also had some great opportunities to be a young person, to be able to run around in the afternoons or weekends and not have to worry about any kind of crimes or those kinds of things. And mom would say, you know, come home when the street lights come on, and then it was time for supper in this Midwestern town. Um, I was born prematurely. For some of those who work in healthcare, you're going to hear me tick off some check boxes for risk factors. I hope you hear the protective factors as well. But the risk factors, I was a premature baby. I had an extended stay in a hospital due to some health concerns. Parents were divorced when I was less than 5 years old, and both were remarried by the time I was 7 years old. We had a great extended family in this rural area where there were lots of good family events and food and laughs and music, and also lots of alcohol and lots of tobacco use. But ultimately we were connected. We had a community connection to our schools, our families, and our community. I also come from a long line of folks, parents and their parents who immigrated into the United States. They also were veterans. We also had lots of low socioeconomic status, and had quite a few, myself as well as my parents and their parents, experienced adverse childhood experiences. So we didn't know that much about that in the 70s. We didn't have a checklist to determine if somebody's at risk for later consequences as it relates to adverse childhood experiences, but we know much more about how important that is. We also had a lot of resilience. We took care of each other when people were having problems. You know, everybody was up all night if necessary. Family was up all night if we needed to be, and really kind of supported activities, engagement at school, those kinds of things. I also had learning and attention problems early on, had learning difficulties, and my mom was very proactive about seeking me extra supports. There weren't in IEPs at that time, and so we got tutors and people to help me. And mostly I checked out a lot. I just didn't pay attention very well. But in that, I was also adaptable. I could figure out how to make friends, and had other strengths besides my learning and attention problems. As I grew up, we moved to the Southwest into Tucson, Arizona. Huge change from a rural town in the Midwest to the Southwest Arizona. With Tucson was just huge to me at that time. And it was right at that middle school age, which I was painfully shy and had really difficult, starting to going through puberty and all kinds of things. And it was really kind of a difficult transition. We lost our family connection, our extended family. Stress, toxic stress, and other factors in the family that made that transition even much more difficult. Became much more impulsive. My attention turned into more impulsivity, and started using drugs and alcohol. Again, even though we were miles away, family support in Michigan, we used the telephone in those days, as well as making sure that we wrote letters. I got letters from my extended family, lots of support, not only for me, but also for my mother. Substance use got a little out of hand, probably too much so that my mom took me out of school because I had missed most of the fall semester. I was out of school more than I was in, and went to residential substance use disorder treatment. The level of care was probably a little bit too much for my severity, but it was available. My mom was working at the residential treatment program, and I had talked about suicide, and I had made some other comments that were quite disturbing to her, that she thought maybe I'd outgrow this phase, but she wasn't sure if I'd live through it. She was more concerned that I actually have the opportunity to live through this phase in my life. And so she worked for the treatment program, and that actually got me into this long-term treatment, and actually was very helpful in who I am today and with the career path and educational path that I made. I have lots of commitment to others, seek out ways to support people who have substance use problems, concerns, disorders. But also as an adult, still struggled in my personal relationships, used alcohol way too much, but also was very professionally productive. Wrote papers, wrote grants, supervised lots of people, made, in my opinion, very significant contributions to the area of behavioral health, and also have a master's degree and a doctorate degree in behavioral health. So in that, I hope you see a little bit of the checklists of the risk factors, protective factors, and how important not only just making a diagnosis of ADHD, but what does that mean, and who we are all so much more than diagnoses, and we have so much more to offer our communities, even in the face of struggles. So let's get into some of the aspects of the study. So I want to let you know that this was approved by Human Subjects Participation Program, the University of Arizona Institutional Review Board, and there's no conflicts, and everything was approved, and we did everything as it was approved. If you want more information about anything that we're about to present, you can find 2 papers. We have a protocol paper, which really dives deeper into the methods that we used for the study, and that can be found in the Contemporary Clinical Trials Communication that was published in 2019. And we're really thrilled that our outcome findings were published in Ethical Human Psychology and Psychiatry just this last December. So you can find more information in those 2 articles. So what is attention deficit hyperactivity disorder? So what's really important to know is that it is the most common neurodevelopmental disorder. So when we think about young people, it is the most common disorder. It is diagnosed via the Diagnostic and Statistical Manual 5, and it provides symptoms associated with two areas: inattention and hyperactivity and impulsivity. And for inattention, there's 9 criteria, and some examples of that are makes careless mistakes, easily distracted, and there's cut scores based on the developmental stage. For hyperactivity, impulsivity, also 9 criteria, and cut scores are also based on developmental stage. There are 4 other criteria that are necessary. So for instance, symptoms have to be present in 2 or more settings. It's really a persistent pattern of inattention or hyperactivity, impulsivity. Symptoms have to show up before the age of 12, and it's not associated with another mental health condition such as schizophrenia, anxiety, or those types of things. And depending on the symptoms, there's 2 presentation types. So either predominantly inattentive or predominantly hyperactive, impulsive, or a combined presentation. What's important for this is that it's criteria present for at least 6 months. So again, we're not looking at just 1 or 2 incidents of inattention or hyperactivity, but there's a pattern of behaviors. And also, we know that inattention is the most common, but yet hyperactivity and impulsivity is the one that leads to the most clinical services. We know that 6 to 7% of children and adolescents are diagnosed with ADHD, so this is definitely a public health issue and a public health concern. And when we look at rural versus urban diagnoses, we know that 11% of rural children are diagnosed as compared to 9% of urban children. So there's differences there. We also know that boys are twice as likely to be diagnosed, and oftentimes it's the hypothesis is that it's because of the observable behaviors of the hyperactivity and impulsivity, whereas inattention, girls might exhibit more inattentive, like I did, but not then get the support and services that they need. And we know that ADHD can continue throughout adulthood. There's about 5% of adults who have a diagnosis of ADHD. Throughout this, you're going to meet 5 of our study participants who shared some introductions about their children or their families. And we wanted to share this again to kind of bring in the human aspect of the study. And so the first parent says, I'm a mother of 2, a girl age 10 and a boy age 7. My son was diagnosed at age 5, and we have sought therapy, medications, and sleep studies. Although he's doing average in school, he struggles socially, and we keep thinking we are missing something. So they were seeking the NHA to help fill, maybe this is something that they were missing. The American Academy of Pediatrics, or AAP, what they recommend for children ages 6 to 11 who are diagnosed with ADHD is FDA-approved medications. There are medications available to treat. They also recommend parent training and behavioral management and/or behavioral classroom interventions. We'll talk about this later, as these are sometimes underutilized, and these are also, but they are recommended for AAP. Also, educational interventions, and to address the issues in the school environment, instructional placement, as well as helping children with learning, and often have some type of IEP plan or rehabilitation plan. This is our second study participant, and they are a mom to twin boys who turn 8 in 2 weeks. This was a couple of years ago, so they're older now. Both have ADHD, and we made the decision to medicate. It's great for them. They decided to engage in dance classes for about 6 days a week. The children really loved it and got out some of that energy and taught them some discipline in a positive way. And they were looking forward to figuring out how to make unstructured time and the time outside of school and dance more peaceful and happy. So what do they do in these unstructured times was one of the reasons that they sought the NHA. And our research question, does NHA, Nurtured Heart Approach to Parenting, improve ADHD behaviors? Just one question. It was a randomized control trial. We had arms. We had the NHA arm as well as the waitlist control. Eligibility is that parents or guardians that had a child in the age categories of 6, 7, or 8 with a diagnosis or a suspected of ADHD. So they didn't have to have a formal diagnosis, but it was suspected. And they had to have access to computer and the internet, because the research surveys were done on the computer, as well as the intervention was completely online. We conducted a pre-survey and then went to randomization. We had 104 parents who were randomized either to the NHA or the control group. We had a nice equal split, 52 in each arm. The NHA got the intervention first, and the control group just went along with their usual activities. And what we did is we did a post-survey to see if there were any differences between the NHA and control group from pre to post intervention. We collected several instruments. The 2 that we'll be talking about here are our demographics form, which is asked about marital status, socioeconomic status, education, and the Connors 3, which was a parent short form, which is a measure that's used for research as well as clinical practice, and it's found to be reliable and valid. Now I'm going to turn it over to Dr. Nuño. Tavalia.
Thank you, Bridget. I appreciated getting to know a little more about you. Will you go to the previous slide, please? Good afternoon to everyone. Thank you for having me. So the Connors 3 short form is the form that we use to measure ADHD, and our secondary measures were stress, parenting stress specifically, and parenting competence. Thank you, Bridget. Next slide. A description of both our parent and child participants. We had approximately 96% women participants, that were caregivers or mothers. 21% identified themselves as Hispanic and 85% as white. They were around middle age, between 39 and 40 years of age. Most of them were biological parents, and we had 12% that were adoptive parents. 85% were in married or marriage-like relationships, and they had a median number of 2 children in the household. A large percentage, well over half, had college degrees or more, and most of our participants, about half of our participants, came from the state of Arizona. 10% came from California, and the remainder of our participants were across the United States and its territories. For our child participants, most were boys, 73%. We had 28% that were Hispanic and 83% that were white. When it came to age groupings, it was about evenly distributed between the 6, 7, and 8-year-olds, with about a third in each of those groups. Most of the children were in public schools, and we had some, 21%, that were in private and 8% that were homeschooled. As far as having a diagnosis of ADHD, about 69% of our participant children had a diagnosis. And of those with a diagnosis, 46% took ADHD medication on a regular basis. Next slide, please. Here we have a quote from one of our parents. "Hi, I'm mom to 2 boys, 7 and 4. We've been drawn to the NHA for a while, but have had a hard time implementing it consistently. We're excited to have the support of this course to help bring us all to a more present and connecting way of relating in our family." This quote was consistent with some of the other comments that we heard from parents, where they have tried different approaches, different therapies, and like has been mentioned before, they find that something's missing. And so in part, some parents were coming to us looking to fill in that missing piece. Next slide, please. So the nurtured heart approach, it's an approach that's been around well over 20 years. It was developed by Howard Glasser, who was the founder of the Children's Success Foundation. Well before he ever became the founder of the Children's Success Foundation, he had another center, a Center for the Difficult Child, which was back in the 90s. And when he had that center, several families would go to him for treatment of their child who was being defiant or difficult, and they didn't know how parents were having trouble figuring out how to manage their child's behavior. Howard, for a long time, tried to apply the different therapies that he had learned and found that he wasn't having success. So he took about 10 years off. He said he went into woodworking during that 10-year period and then felt ready to come back to the world of family therapy. It was during that return that he started to have insights about a different way of working with children and families. And it was through this becoming more aware of what young people would be responsive to, that process, that he developed this approach. He started to see improvements. By using the approach, he started to see relationships improve between children and parents. And he also started to get referrals with children that were having the most difficult time, that might have been on probation or struggling in school, had gang involvement, and he was even noticing change among these young people. So let me tell you a little bit about the Nurtured Heart approach. I have been certified as a Nurtured Heart approach trainer. This means that I have gone through a 40-hour training in person by Howard Glasser, and I've also participated in the online trainings. So I can deliver the Nurtured Heart training to people one-on-one and also in groups. So the Nurtured Heart approach has a core methodology. But first, the Nurtured Heart approach it's a relationship-focused methodology. founded strategically in the 3 stands. And the 3 stands you see here on the slides. The 3 stands are designed to help children and adults build something they call inner wealth. And they use their intensity. So young people use their intensity in successful ways. So rather than seeing the behaviors that are seen as difficult to manage as something that needs to be fixed, it is instead something that should be embraced and used in a way that's successful. So this is part of the reframing of the behaviors in children that's taught to parents when they participate in the nurtured heart approach. So here in the nurtured heart approach isn't so much a one-time intervention, but more of a lifestyle. It becomes a way of life. So to this end, the goal is transformation. It isn't just change from pre to post, but a different way of relating between parent and child. It works to help the parent as well as the child and the parent-child relationship. So here we have the core methodology. The first one being absolutely no negativity, followed by absolutely yes to positivity and absolute clarity. So let me explain these a little bit more. So stand 1, there are 3 stands, which are the core methodology. The first one is about negativity. The first one has to do with whenever a child misbehaves, the typical reaction of adults is to really give them full-on attention, surrounded by a lot of negativity, telling the child about how to behave better. That same level of energy and attention needs to be applied to children when they're engaging in neutral or positive behavior. So the point here is absolutely no negativity, so not to engage in anything negative towards the child, and to focus more on the next stand, which is positivity. When the child is behaving neutrally or in a way that's desired, to apply the same level of energy and enthusiasm and focus as one would apply whenever they were reprimanding the child. For stand 2, related to positivity, it involves being very creative and predictable and energizing that moment in time when the child is engaging in neutral or positive behavior. So for example, all of you at this moment are on mute, but I would imagine that you would all be very attentive and listening to me. And so I would acknowledge what this behavior, what might be seen as neutral, but acknowledge the fact that you are showing such respect and attentiveness and how much I appreciate that. So it would be acknowledging everyday moments. And when you look at a sheet of paper, and say I had this yellow sheet of paper, and it had a single dot right in the middle. When you look at the span of a whole day, this being the whole day, the amount of time the child is engaging in negative behavior might be the size of this dot. Most of the time, if you really look at it and really were honest about the child's behavior, most of the time that child is engaging in neutral or positive behavior. And so honoring that time when they're not engaging in misbehavior. And the last stand is stand 3, which is absolute clarity. This has to do with the setting and enforcing of clear limits and consequences in an unenergized way. So as a parent, I have 2 children, 17 and 13, and I've run many after-school programs, worked with lots of young people. And it is very easy early on, before I learned this approach, to energize the negative behavior or give consequences with a lot of negative energy that included my frustration. And so the nurtured heart approach teaches one how to reset themselves, much like you would reset your computer or reboot it. We reset ourselves in order to give a consequence and set limits. So stand 3 is about enforcing and setting limits and giving consequences in a way that does not leak out any negativity. Next slide, please. The book you see on this slide is available. It gives you all the details related to the approach and how to apply the approach, along with lots of stories and examples. So if you're interested in learning more, I highly recommend the book. So for our study, we had involved parents in a 6-week online course. Each week we had a slide presentation that was narrated by Howard Glasser, the developer. Once parents went through that slide presentation, they were asked to read from the Nurtured Heart workbook. And in this workbook are several stories and actually words that communicate positivity and ways to talk to a child. When they finished that piece, they were asked to practice. Now go and apply what you've learned, and then post what their experience was during their application. At the end of the week, there was a 1 hour and 15-minute live forum where advanced trainers, as well as Howard Glasser, fielded questions from the audience, but also highlighted themes for that week, whether those were related to the posts or related to the slide presentation offered on Mondays. Next slide. So here we have the study results. We had 87 surveys that had a pre and a post measure. Along the left side, the first column are the ADHD subscales. So we had inattention as well as hyperactivity, impulsivity. These two were our primary outcomes related to ADHD, but we also measured learning problems, executive function, defiance, aggression, and peer relations. The two middle columns are the two groups. So we had the Nurtured Heart group, and then we had the control group. And then the final column is whether we saw statistical significance or not. So taking a look at inattention, that column, that first row, for the NHA group, we saw a decrease in inattention. In fact, it improved. So if they have a minus in front, that means an improvement. So they dropped in inattention, so they improved in their inattention, whereas the control group had a less than 1 point score change. Was it statistically significant when we compared the Nurtured Heart group to the control group? Yes. When we looked at hyperactivity and impulsivity, we saw a nearly 8-point improvement. So that minus 7.9 is actually about an 8-point improvement for the Nurtured Heart group compared to half of improvement in the control group, half of a point of improvement. The difference between the two groups was statistically significant. So the first two were our primary outcomes, but we saw improvement in learning problems as well as executive functioning. So in learning problems, we saw a 4.5-point improvement, whereas in the control group, it was a less than 1 point improvement. Executive functioning, we saw a 6-point improvement, and in control, we didn't see an improvement. And defiance and aggression, we did see an improvement in the Nurtured Heart group, but it was not statistically significant when comparing the Nurtured Heart group to the control group. And finally, when it came to peer relations, I can't see that on my screen, but I can tell you that we did not see a difference between the two groups. So overall, we saw improvement in 4 of the 6 measures for ADHD. Next slide, please. When it came to relevance to practitioners, so just looking at inattention, we checked on clinical relevance. So here we have just the pre-survey on the top and then the post-survey results. So the pre-survey, 74 of the 87 surveys that we had where children had elevated scores for inattention. So on the right-hand side in the white box, we have the definition of what's considered elevated and non-elevated. So greater than or equal to a score of 65 meant that the symptom was elevated. In this case, the symptom was inattention. If the child had a score of less than 65, inattention would be considered not elevated. So we just had this two options, this one cutoff point at the number 65. So 85% of children at pre-survey had elevated scores. This means that 85% had greater than or equal to a score of 65. At post-survey though, which means after the parents had gone through the nurtured heart approach and were applying the approach in their families, at post-survey, 31% of NHA group versus 2% of the control group dropped to non-elevated scores. This is saying that we saw an improvement from pre to post, but that the children, when it came to inattention, dropped to the level of no longer being elevated. Of the 10 children, so it was 10 children, 31% of the nurtured heart approach group, 9 were over 70 at the pre-survey. After the intervention, of these, 4 were in the 60 to 64 range, and the other 6 were less than 60. This is a very full slide, but in essence, what it's saying is that we saw children go from being elevated to non-elevated in our study when it came to inattention. Next slide, please. Hyperactivity and impulsivity, same cut point of 65. 90% of the children had elevated scores in hyperactivity and impulsivity. At post-survey, 11% compared to 2% in control dropped to non-elevated scores, and that was statistically significant. Of the 4 children that had shown the improvement in the nurtured heart group, all 4 were over 70 at the pre-survey point. After the intervention, all 4 were 60 to 64. So if you're a parent who's raising a child that has a high level of intensity, watching your children drop to lower levels of intensity can be a wonderful experience. Next slide, please. We did subgroup analysis where we looked at sex, the influence of sex, age, and ADHD medication use. Although we were not powered to detect these differences, the results were similar across all the subgroups. When we separated the young people, we separated them by sex, so female to male, by age 6, 7, and 8, and ADHD medication use, whether they used medication or didn't use medication. We did not find any significant interactions between the nurtured heart intervention and the child's sex, age, or ADHD medication. Next slide, please. One of the study parents said to us, "Our older son has been a challenge, particularly over the last 4 years since the birth of our younger son. He is bright, intense, and highly persistent, and stretches our capacity to be calm, clear, and patient. Even doing just the first week of the course has helped us feel more hopeful that we can get on track and feel more successful and appreciative of who he is and feel more successful as parents." Next slide, please. Another parent said, "I'm also a behavioral health special education teacher for ages 3 to 8. What works at my job just never works the same at home." So this slide is here because we heard from parents who work in this field, work in behavioral health or work in education. And And although we did not study this in our research, parents who had a background in behavioral health, who were seeing success at work, but were struggling at home, seemed to be especially hard on themselves because they weren't able to carry over the success they had at work into their home life. And I just wanted to point that out, that the amount of shame and embarrassment that parents felt around that, and to just emphasize that it's very different to be working with children versus raising your own children. There's different aspects that come into raising your own children and challenges associated with that and emotions. So we have more work to do in this area, but I know that the audience comes from rural communities, and some of you may be providers, and some of you may be raising children that have ADHD or have ADHD behaviors. And I just want to acknowledge that there is support, and while you may have success at work and it may be difficult for you at home, that seems to be a very common theme. Next slide, please. So finally, a synthesis. Our study strengths is we have some preliminary evidence of effectiveness. We saw a reduction in inattention, in hyperactivity and impulsivity, and in parenting stress. We did not see a reduction in or an improvement in parent competency. Our study limitations our findings are not generalizable to all children. We did focus on 6 to 8-year-olds. Our study population engaged mostly mothers, mostly boys, mostly college educated. So keeping that in mind when considering the implications of the study. It was also a self-report, so we did not have objective measures that would strengthen the study. Next slide, please. Bridget, I'll turn it over to you.
Thank you. Thank you, Valia. I'm always loved the way that you synthesize our work as well as the parents' experiences. So just very quickly, we won't spend too much time on this, but it's really important to think about, is Nurtured Heart approach scalable? And one thing to keep in mind is that psychosocial interventions are underutilized in ADHD treatment, and there is fragmentation in care. So we know that medication is usually kind of the first go-to, and psychosocial interventions are clearly underutilized. Kind of thinking about changing the paradigm for that to more of a life course approach to supporting parents and children, changing it from an acute care or an incident or some type of activity that gets the family, quote, in trouble or has concerns and goes to the doctor, to more of a chronic care model, working with the family over time throughout their lifespan. The primary care medical home, or the PCHM, is a promising model. There was a study done that looked at children with ADHD who received care via the PCMH and those who did not. And those that did have the primary care medical home model utilized treatment, and their functioning improved as compared to those that did not. So Milat and colleagues indicate that scalability means that you take an efficacious model, NHA, expand it into the real world, and see if it retains its effectiveness in order to reach more people. There are different healthcare models of approaches. There's the collaborative care model or the integrated behavioral health model. These models intentionally organize treatment based on the needs, preferences, and shares information for the purpose of improving safety and effectiveness. So it really puts the patient and the family at the center and responds to their needs. Examples are the patient-centered medical home that I just talked about, federally qualified medical health centers, which Arizona has many throughout our rural counties, school-based health centers, as well as the nurse-family partnership, which is trained nurses that go out into people's homes, primarily first-time moms that might be at risk, and work with them on their healthcare and understanding parenting. And what they've found is that as compared to families that didn't have a nurse-family partnership, those that did, those children used alcohol in lower rates as compared to families that did not get the nurse-family partnership. So that's an effective approach. There's hub and spoke models, which I'm going to talk about in a moment, as well as the University of New Mexico developed a project extension for community healthcare outcomes, which is Project ECHO, which has been used as a telementoring way to engage rural communities as well as other under-resourced areas to provide the mentoring and support and expertise that communities need. One example of a hub and spoke, there was a publication that talked about a rural hospital, I believe it was in Alabama, that was operationally struggling. They got in connection with an urban health system and kind of started talking. And what the urban health system found was the rural hospital had skilled and competent staff. They just really needed some support operationally. The rural hospital was part of this community. It had a presence. It was well known and utilized. What they decided was that they would partner. The hub would be the urban health center. The spoke would be the rural hospital, and they would partner so that the rural hospital got the operational support and the urban health system got a greater marketplace for services and larger patient count. And through this partnership, what they found was they turned the rural hospital actually into a rural health system that now includes primary care, wellness, physical fitness, and other types of activities. So what ended up happening as just kind of an initial hub and spoke, it actually transformed the way that healthcare was done in that rural community. So our question is, what if the NHA was implemented within one of these models for scalability purposes? We have some resources that we'd like to share with you. I think Rebecca's going to put these in the chat box, but there are resources. The Arizona Department of Health Services has children and youth special health care needs. There's lots of great resources there. SAMHSA has helplines and treatment. I found actually in Chicago, there's actually an ECHO program specifically dedicated to pediatric attention deficit hyperactivity disorder. And if you want more information about the Nurtured Heart approach, you can visit the University of Arizona's website. And just want to acknowledge all of our people who funded this project. Was made by private donors, organizations, and group fundraisers. And for more information, there's Valia's contact information. And I think we're going to stop there and pause for some questions. So if you have any questions, please add them to the chat box.
While we're waiting for questions, I wanted to acknowledge that our other co-investigators on the study were Betsy Wertheim from the Arizona Cancer Center, Dr. Denise Rowe, and Dr. Richard Wall from the College of Medicine.
Hello, this is Rebecca. There's a comment here that I like to read. Didn't see any questions, but I'll read the comment here. It says, good afternoon. Thanks for this fantastic presentation and work. I'm part of the volunteer board for the Arizona School-Based Health Alliance. If you ever need connection to school-based health centers, I hope you'll consider reaching out to us. And there's an email provided.
That's fantastic. Thank you so much for that offer.
there aren't any questions that I can see.
Well, we really appreciate your time. Valia, did you want to say something?
No, thank you. I appreciate Castleyn's comment.
Oh, excuse me, I like to say something to remind the attendees to complete the survey at the end of the presentation.
Thank you, Rebecca. Yes, please complete those surveys. The links on the slide, as well as it's probably in your chat box. Those are really important to this project. And if you're interested in other webinars as part of the State Office of Rural Health, you can visit our website. They're all listed on the Arizona Center for Rural Health's website. And you can always reach out to Jennifer Peters, who is responsible for the SOAR webinar series. Jennifer and Rebecca. And with that, we'll give you a few extra minutes back in your hour, and we really appreciate your time and commitment to rural health and urban health as well. So thank you, children, youth, and families. Take care.